Hello and welcome, and thank you for joining us today live or on the recording for episode 16 of Dr. Jeff Talks About Sex and Intimacy, Ejaculation Disorders in Men, Causes, Treatments, and Solutions with Dr. Alan Shindel. I can't express to you how much it means to me that you have taken time out of your busy schedule to join us. We are so glad that you are here. And we are on social media, in case you're looking out there. We're out there on Facebook, YouTube, X, and those social media sites you see there. If you're a Facebook person, we need 100 followers on Facebook. So please follow us on Facebook so we can stream live there rather than recordings as well. But you can watch us. If you want to find our recordings, go to the website. The website is where you can watch previous episodes, and there's all kinds of wonderful guests to watch, and please do so. You can see the calendar for upcoming episodes. We have a lot of wonderful things planned for you. We're planned out all the way through July, and you can see what's coming up, and we hope you will join us for some of those. Or you can also listen in your car, wherever you are. We're on Spotify, iHeartRadio. Don't forget, we're there where you are, so you can listen to us there as well. I just want to remind you again today that all are welcome here. Whatever your sexual orientation, whatever your gender identity, or your relationship style, you are so welcome here. We are so glad you are here with us. So what's this podcast about? If you haven't been here before, the goal of the podcast is really very simple. It is to empower and enlighten you with the evidence-based information that you need, the scientific information you need to improve your sexual health and to deepen your relationships. Well, it's been a very interesting week, and I woke up Sunday with this crazy vertigo thing. I mean, the room was just spinning out of control. And I am not a person who enjoys spinning rides. And so they make me very, very sick. So I got very, very sick Sunday morning. I was supposed to sing. I was supposed to do a lot of things Sunday morning, and it did not happen because I was basically on the bathroom floor. So any of you out there with vertigo or those inner ear issues, I have the greatest sympathy for you in the world now, because it has been a real struggle this week to function in my life, given some of this vertigo stuff. But anyway, no worries. Now the doctor's given me exercises and some things to help, and it is helping reset my inner ear. I don't even know how the heck, neither does my doctor, these things necessarily occur. I didn't have a head injury or anything, but here we are. Anyway, so today we are talking about ejaculation disorders, such as premature, delayed, or absent ejaculation. Although these things are common, they're often misunderstood aspects of men's sexual health. Now, you might recall that in episode 13, psychologist Dr. Stanley Altoff focused specifically on premature ejaculation. So we had a talk on that. But in this episode, we're going to talk about that and expand to other ejaculation disorders. I am joined by expert urologist Dr. Alan Shindel, and we're going to unpack ejaculation disorders and discuss the causes. We're going to talk about available treatments and solutions that can improve confidence, that can improve intimacy, and quality of life. Whether you're personally affected by these problems or you're supporting a partner, this conversation offers you compassionate, evidence-based insight into often taboo topics. We're going to talk about it all. And I am so happy we have the most amazing expert. He is the man when it comes to this information. Dr. Alan Shindel is a board-certified urologist who completed a 3-year research and clinical fellowship in andrology, which is men's reproductive and sexual health, at the University of California, San Francisco. He's a professor of urology at the University of California, San Francisco. And in addition, he is a renowned speaker and author. He has published and written on this subject, and we are so lucky to have him. In addition, he is the editor-in-chief of Sexual Medicine, an open access journal of the International Society for Sexual Medicine. So he's editor-in-chief of that, but he is the expert on this. And Dr. Shindel, thank you so much. I know you're such a busy guy, and we have American Urologic Association conference coming up. Thank you for taking time out of your incredibly busy schedule to share your amazing expertise with our listeners.
Well, Dr. Alba, it's my privilege to be here, and I appreciate so much you inviting me, and I appreciate everyone who's attending, listening on the recording, however you're choosing to tap into this contact. It's really a privilege to speak to you about this topic that has been near and dear to my heart for well over 10 years now, since I've really been engaging with this field and kind of studying this particular aspect of sexual function in men. I have, as Dr. Alba implied, I have covered the topic of both premature and delayed ejaculation in this presentation. I know that my good friend and colleague, Dr. Althoff, has done a spectacular job in episode 13 covering some of this material. There may be some overlap. I'll try to give you the medical perspective on some of this to kind of complement what Dr. Althoff had to say, and I'll elaborate on some other things, but I do want to leave time for the discussion about delayed ejaculation, or DE, to invert the thing that we're so familiar with. We know about ED, but DE is actually a very common and poorly understood condition that can pose a pretty substantial impediment to men's sexual quality of life. So we'll spend some time talking about that as well. Am I able to share slides here? Oh, here we go. Perfect. Thank you for that. So this is my title page. Before I go into the presentation, I want to make these disclosures. I have financial relationships with two companies, both nonprofit, I believe, neither of which is really germane to the topic at hand, that is to say, disorders of ejaculation. I do receive compensation for services rendered to a number of nonprofit entities. And I want to be very clear also that any pharmacotherapies, any medical treatments that I describe to you in this entire presentation should be considered off-label, meaning none of these drugs, in fact, there are no drugs that have been approved by the FDA for the treatment of any disorder of ejaculation in men. That doesn't mean that there aren't treatments available, but all of them should be considered off-label because they have not been formally vetted nor approved by FDA for this particular purpose. So my intention over the next several minutes is to go over what are the evaluation steps and how do we prescribe treatment for these disorders of ejaculation. I'd like to, also make clear what are the criteria for these different diagnoses, because I think there's a lot of misconceptions, a lot of missed ideas about what is and is not premature ejaculation, and DE to some extent too. And then also go over some of the treatment options that are available and may be accessible to people struggling with these issues for both men and their sexual partners. So first off, level setting and defining some terms here. Sexual climax, peak arousal, as defined by Masters and Johnson and many others, is typically, in the case of men, associated with both orgasm and ejaculation. These are simultaneous. They're kind of used interchangeably when you talk about the literature, but they are distinct processes. And they are really a reflex, a kind of a neuroreflex that occurs in response to sexual stimulation. And many men experience this sensation of that right before orgasm, a sense of orgasmic or ejaculatory inevitability, which I think is very relevant to when we talk about, well, how do we manage these conditions of disorders of timing of ejaculation? That awareness and sense is something that I think in many cases may be missing from some individuals. I'm not a neurologist, so I don't want to belabor this too much, but just as basic principles to lay out there. There are a central nervous system, that is to say the brain and the spinal cord, are very important in modulating ejaculation and orgasm responses. In fact, orgasm occurs entirely in the brain, but the spinal and brain reflexes that control the ejaculation process are delineated on this slide. In a very simplistic fashion, we can say that serotonin, a very important neurotransmitter, generally opposes ejaculatory reflexes, whereas dopamine has the opposite effect. So keeping this in mind, this does inform some of the treatment options that we're going to be discussing later on during this presentation. Ejaculation itself, in terms of what happens peripherally, that is to say within the pelvis, is also under control of the nervous system and is divided into two distinct segments. There is emission, which is deposition of semen in the posterior urethra, the tube through which urine is expelled. And then there is ejection, which occurs under the influences of the somatic muscles. So the muscles that we oftentimes call Kegel muscles, they're not actually called that, but the muscles that are contracted with what everyone knows as Kegel exercises are very instrumental in triggering ejaculation and forcing semen out. Now, before the question comes up, I will say that Kegel exercises are not really reliably, or at least conclusively, linked to changes or improvements in ejaculation function, but those muscles certainly do play a role here. And it is something that we want to be aware of, because these are all things that may play into any disorder of sexual activity or ejaculation that can occur in the context of sexual acts. Orgasm is something that's somewhat hard to define, but this is what Webster's had to say about it. I think it's a pretty decent definition, and pretty much if you've had one, you know what it feels like. It is, as I said earlier, distinct from what happens in the pelvis, and it can occur separately. It is possible to have an orgasm without ejaculation and vice versa. As I alluded to earlier, there's a lot of neurotransmitters, a lot of central nervous system activity that is involved with and is tantamount and really essential for orgasmic reflexes. But it's something that remains not terribly well understood, and for which we don't have a whole lot of really good pharmacological options for managing or improving it, although we do have some things we'll sometimes try. So having established, again, and very briefly, some of the different considerations that are relevant to ejaculation function, let's talk about some disorders of ejaculation. We know these are very bothersome. We know these are very common. There's things we do understand about pathophysiology, meaning why do these things happen to people? And we have a number of options that exist that are strongly evidence-based and have been shown in multiple randomized controlled trials to help yield improvements for these various conditions. And we'll go over that during the course of this talk. Now, we recently completed a document for what was called the International Consultation on Sexual Medicine. This was actually published just a few months ago, in which we discovered a number of, we discussed a number of other conditions that are relevant to ejaculation function. Now, during this presentation, I'm going to spend most of my time talking about premature and delayed ejaculation, that is to say, disorders of the timing of sexual climax in men. However, we have these other conditions, including lack of pleasure with orgasm, also known as anhedonic orgasm. We have painful ejaculation. We have blood in the semen. We have a rare and poorly understood condition called post-orgasmic illness syndrome, which many men do experience, and also retrograde ejaculation, meaning semen going backwards into the bladder instead of forwards. These are things that I can certainly discuss. I won't prioritize them right now, but if questions come up, I'm happy to discuss them to the extent that we have time available to do so later on during this presentation. So briefly, what I'm going to base this talk on is an AUA guideline. So I was privileged to be the chair of the Ejaculation Guideline Committee of the AUA, which convened in 2020. Interesting year to having a meeting like that, but we convened and put out our guideline at that time and published it subsequently in 2022. So this represents a lot of work, and I give American Urologic Association a lot of credit for funding the work. I give my co-panelists who volunteered their time. We weren't paid for this, really. We kind of did it on a volunteer basis for crafting this document that's really meant to provide healthcare providers and patients with something to work with and really give them the best possible evidence on how to treat these conditions. So first off, what I want to say, and if you read literature on this topic and if you kind of talk to the lay community, you'll find a lot of people saying that premature ejaculation is an epidemic. It is the, quote, most common male sexual dysfunction. And you'll see numbers 30, 40, 50, 70%, sometimes in the most extreme cases of men diagnosed with premature ejaculation. And this is from studies from all around the world. Oftentimes you'll find levels that really reported to be this high. The issue with these reports are that they are based simply on a patient or a participant in these studies endorsing, like, at some point in the last year, I did ejaculate before I wanted to. And I think it's important to recognize that that sort of experience is not rare. Many men wish they might last longer during sex. That doesn't necessarily constitute what we would call clinical premature ejaculation. In fact, what we know is there's a lot of variability. These are data from a great researcher, late and lamented Marcel Waldinger, who was based in the Netherlands and did a lot of work actually having couples take a stopwatch. These were all heterosexual couples. That's where the data exists. But heterosexual couples engaging in intercourse and using a stopwatch to time the duration between penetration, in these cases vaginal intercourse, and ejaculation. Now, what you'll see on the left is a representation of the ejaculation latency. So again, the duration in seconds from penetration to ejaculation during these heterosexual encounters, primarily in Western countries. You'll see that most men were ejaculating within about 4 to 5 minutes. And really that was sort of the normal, but there was certainly a lot of skew and variability here. The bottom 2.5 percentile of this group were those who ejaculated in less than 1 minute. And these were sort of defined semi-arbitrarily as the cut point in Dr. Waldinger's initial studies on what constituted premature ejaculation. Some of the older criteria that were used to diagnose PE prior to the AUA guideline and some others really said that the important thing was sense of poor control and bother. And what you'll see from this, and again, it doesn't show up terribly well on this small slide, but you'll see that these very dark black boxes on the right side of the table represent men who ejaculate in 1 or 2 minutes or less, but really weren't bothered by it. And at the other end, you can see a couple of light gray boxes on the right-hand side, once again, highlighted with the red box, showing men who were distressed and bothered by the fact that they were ejaculating too early, but having latency times that were double or sometimes even 4 times the typical. So again, men who would have latency times of 12 minutes, 20 minutes even, and still feel bothered by it. And this really represents a problem with the data and how we were collecting it. And really, it's a bit too much to say that 30% of these men are premature ejaculators based simply on their own self-report. And Dr. Althoff, my esteemed friend from episode 13 of this podcast, really kind of articulated that realistically, we're only talking about 5%, which is still a pretty high number of people having either acquired APE or lifelong LPE premature ejaculation. So still a very important problem, although not perhaps an epidemic the way we might have thought. So these are the definitions. And what I really want to make clear about this is that for both lifelong and acquired premature ejaculation, based on what the AUA had to say about it, you have three really fundamentally most important criteria. Number one, an absence of sense of control. Number two, bother, and that could be personal bother, partner bother, both bother. And three, a latency time that was substantially below what we see as mean or normal or typical values in general populations. And with the number that was selected by AUA and recently resupported by the International Consultation on Sexual Medicine is about 2 minutes for lifelong, and somewhat nebulously defined as a marked reduction, again, typically meaning down to half of prior duration or maybe 3 to 5 minutes at most for the acquired definition. So again, highlighting here the three fundamental criteria that are most important when making this diagnosis. Latency time is short, lack of sense of control, and it's bothersome to the couple. And if these three criteria are met, a diagnosis of premature ejaculation may well be appropriate. So I alluded to earlier how a lot of people might report premature ejaculation when they're not thinking about those three specific criteria. So what do we do with these other patients? Again, Dr. Waldinger had a notion that there were probably plenty of men out there who, at least on occasion, will experience ejaculation that occurs quite quickly after penetration. And this could be because, number one, they maybe haven't had sex recently. You know, the ejaculation latency does shorten when intercourse is less frequent. It could also be younger men or men early in a sexual experience or in a new sexual relationship will oftentimes also have some shorter ejaculation latency time. So this is sort of normal and almost natural, you would say, and not necessarily indicative of a serious medical problem. There also exist a number of men who are really troubled by the fact, and really, even though they might have normal ejaculation latencies, you know, last a long time, it might even, in fact, be more than enough intercourse duration to satisfy a partner, but remain very troubled by it. I think in some cases, this may stem from the notion, again, thinking primarily about heterosexual couples here, a notion that some men have that if they last longer, if intercourse lasts 10, 15, 20, 30 minutes, that will almost assuredly lead to their partner being more satisfied and potentially climaxing. That could very well be true, and there certainly are individuals who might climax from that. But I think there's also an important thing to realize that in terms of, again, heterosexual relationships specifically, many women do not and will not climax from intercourse alone. And therefore, this notion that longer is always better, at least in terms of duration of intercourse, it may not always be the case, once again, in any sexual relationship, and specifically, clearly, in many heterosexual relationships. So again, communication, what do people actually want, and actually having that conversation between partners is a really important part of how we manage this kind of condition. So providing counseling and education, really key for these particular populations. So Dr. Althoff does this more justice than I ever could, so I won't spend a lot of time talking about it, but sex therapy works, it's important, it's valuable. It can lead to a sustained benefit in these couples struggling with ejaculation issues of any type. So I'm very strongly an advocate and believer in this and what people like Dr. Althoff do for people. From the medical perspective, you know, in the way that I evaluate a person with premature ejaculation, you know, we generally have to take a sexual history, talk about what's going on, talk about the partner. We don't routinely recommend that stopwatch assessment is necessary because honestly, an estimate is close enough for clinical work. So we don't make people do the stopwatch thing like Dr. Waldinger did, but certainly for research studies, it can be very valuable. There are a number of validated instruments. Once again, if you were in a doctor's office, you might encounter a number of surveys. These are ones that are probably not utilized that often in clinical practice, but they are used, once again, quite commonly in research to help us track response to therapy and also to assess criteria for involvement in clinical studies. So again, you may or may not encounter these if you go to see a doctor to talk about PE. These are things that they might use to kind of stratify risk. It is not thought to be useful to obtain any specific blood tests for a man with lifelong PE, meaning PE that has occurred in most or not all cases since sexual debut. However, when a man has a change, when his ejaculation latency certainly changes, there may be some blood testing or other testing that might be indicated, including assessment of testosterone, thyroid hormone, urine testing to screen for infection, perhaps some other basic metabolic labs. And those are sometimes done for the context of premature ejaculation that is acquired rather than lifelong. And that is the current state of the art. This may change as new data emerges, but that's where we stand right now. In terms of pharmacotherapy, the AUA guideline did articulate that there is evidence to support the use of on-demand, daily dose SSRIs, so drugs such as paroxetine, fluoxetine, sertraline, citalopram, all of which have an evidence basis as management options for PE. You can also consider a drug called a tricyclic antidepressant known as clomipramine, and also topical penile anesthetic agents, all of which are considered first line, meaning any of these would be legitimate as starting options for a man who wishes to pursue pharmacotherapy for PE. Again, the question becomes, what is the risk tolerance and what particular drug option is most appealing and safe for that individual man? So SSRIs have been around a very long time, over 30 years at this point. They've been very effective in the management of mood disorders, and the fact that they use our serotonergic drugs, as I started this presentation talking about, serotonin is very anti-ejaculation, to oversimplify things. And for that reason, these drugs, which augment serotonin activity in the brain, have been shown conclusively and reliably and repeatedly to yield improvements or at least lengthening of ejaculation latency in men taking them. This can be a problem when a man goes to the point of not being able to climax at all in relation to these types of drugs. But at the proper dosing and in the proper patient, this can be a real game changer and make a big difference for a lot of these patients. Again, it is available, and these drugs can be utilized as on-demand treatments, but it's generally a lot less effective. So generally our recommendation for most people taking these for premature ejaculation is to take them on a regular basis, that is to say every single day. So this is what's called a meta-analysis, where a bunch of different studies are basically compacted into one large study. This is an older one, it's from quite some time ago. But it very clearly articulates how either on-demand or daily dosing of these types of drugs leads to very substantial increases in intravaginal ejaculation latency time, i.e. ELT. And again, I'll use the term ELT because these studies were exclusively done in heterosexual couples. We have no reason to believe the results would be that much different if these were non-heterosexual couples or non-coital intercourse, meaning non-vaginal intercourse encounters. Although I'll be honest, data on this aren't really that robust. We don't have as much data in other populations, as much as we've tried to recruit for it and study these populations aside from heterosexual groups. It has been difficult to do these studies. So we still use these treatments outside of this context, but there's not as much published data on those particular situations. Data here, again, a meta-analysis looking at topical anesthetics, and as you might expect, these drugs can be very beneficial by basically decreasing sensitivity of the penis. As you might expect also, they sometimes are not so desirable in terms of causing some numbness or some difficulty. And certainly if the penis becomes totally numb, they can be actually quite counterproductive. So this is something that really requires some close adjustment of dosing and leaving it on just long enough to reduce sensitivity, but not so long that the penis becomes totally insensate, because that really, again, defeats the purpose. Some other options that are talked about, and again, I've not typically gone to these nor had to in most of my patients, but there is a opioid analog called tramadol, and obviously we're all very aware of the negative impacts of opioids. So while tramadol has been shown in a number of studies to produce improvements in ejaculation latency, it's a drug that I don't think I've ever prescribed just because of concerns I have about it. And also some notions that there are some other drugs most commonly utilized for the management of prostate enlargement to help improve urination. There's some rationale these can also be beneficial, but again, this data is quite weak, and I've again not typically seen a whole lot of benefit from these, even though they are mentioned in our AUA guideline. So briefly, again, evidence here from either central or peripheral mechanisms that tramadol could potentially help. And again, the data suggests that it certainly can. Once again, the benefit is relatively mild, and I think the risk is rather substantial, so not something that I typically will prescribe for patients. I think I'll kind of skip over alpha blockers. A lot of discussion, a lot of people have very strong opinions about circumcision. So it comes up not infrequently, no pun intended, that people are concerned that circumcision has either a negative or a positive effect. And what we know from the data that exists, highlighted right here, is that there is no conclusive, consistent influence of whether a man is circumcised or not in terms of ejaculation latency. Now, there may be individual men who have bothersome issues with the foreskin and choose to have it removed, and therefore, after that experience changes, either positive or negative, in terms of ejaculation latency. So that doesn't mean that there is no relationship whatsoever for each individual case. But I really want to emphasize that what this has shown us is that if you look at populations as a whole, circumcision does not, in and of itself, change ejaculation latency, and nor do we recommend circumcision strictly as a treatment for any kind of disorder of ejaculation, unless there's some other pathological process occurring to the foreskin that's problematic. There are a number of surgical approaches, which again, I won't belabor these. These are typically done in other countries, that's where most of the data comes from. And most of us, who deal with this field and talk about it in this country, have a lot of reservations about any kind of permanent procedure, and certainly any procedure that involves destroying or ablating nerves. We have a lot of concern about that because this is potentially irreversible and could have a very impactful negative influence on sexual response. So not something we recommend, but certainly an interesting research topic that may be worthy of further investigation. So let's talk a little bit about delayed ejaculation now. And again, delayed ejaculation, the AUA definitions, you'll see they're relatively similar because we're talking about the same basic concepts. This is either lifelong or acquired. That's the distinction we again want to make, because we think these are different entities. It is consistent inability to achieve ejaculation, sort of the reverse of what we see with the PE population, and once again, bother. So when this is not bothersome or causing issues, we don't really want to make a diagnosis, nor do we want to treat it. But certainly when a man and his partner or partners are bothered, don't have a sense of control, and are really lasting much longer than they or their partner are comfortable with, or it's causing them pain or exhaustion, we would consider the diagnosis of delayed ejaculation and orgasm in those particular circumstances. And again, there's some distinctions here, because there is delayed, which means you get there eventually. There is anorgasmia, meaning orgasm doesn't happen, and probably neither does climax. And then there's some other kind of more subtle and poorly understood conditions, such as a lack of pleasure with orgasm or semen going backwards. And all of these really have different impacts and feel differently and are basically differently problematic. Because many men, especially once they're past reproductive years, find that while they may miss ejaculation, it's not really the most essential component of sex for them. So absence of ejaculation may not be as big a deal as absence of orgasm. So we really want to make sure when we talk to patients, we use this kind of wireframe diagnostic schema, where we want to first off take a history, talk to the patient, check some labs, get a sense of what this means and what the problem is, and really kind of lay out and distinguish, are we talking about absence of orgasm? First question, does the patient have a climax or not? Okay, if there's climax or not, you then go down this little flow chart, and you can explore in more detail, is there a problem specifically with ejaculation? And that's the problem. And again, these are things that, once again, there's different ways you go along this pathway, but the framework and the kind of the idea of first off working out, is there an orgasm happening? Is there climax happening? That's really the kind of fundamental first question. And then figuring out from there what else is different or changed or bothersome about ejaculation, and making the determination based on these criteria. Okay, what is the problem and how can we potentially help mitigate it? So another great researcher on ejaculation disorders is named Dr. David Rowland. He works at Valparaiso University. He's been extensively published, a lot of important work, and I give him a lot of credit over the last 5 or 10 years of really prioritizing investigations of delayed ejaculation, because I think it's oftentimes underdiagnosed. We don't have good prevalence data. As much as I think we overdiagnose premature ejaculation, I think we as a medical and mental health community underdiagnose delayed ejaculation. We know a lot about erections. We know some about premature ejaculation. There's a lot we don't understand about delayed ejaculation, and a lot of things that we don't necessarily know how to manage. So these studies were very important. They were collected, basically online survey studies, a very inclusive study design, which I really appreciated, as opposed to much of the existing data where it's pretty much all heterosexuals. These studies included men of any sexual orientation. They were, however, all in relationships and able to masturbate, and they basically did not have premature ejaculation. Those were the inclusion criteria for participation in this study. And I won't go over every single study or paper that came out of this data set from Dr. Rowland and his team, but I'll highlight some of the more essential and important ones right here. So this study was important because, as you saw in my definitions up front, I didn't have time-based criteria, and the AUA definitions or the AUA guideline does not currently have time-based criterion for what counts as delayed ejaculation. However, these studies that Dr. Rowland did, and really kind of trying to explore, well, what is too much? What is too long? Identify that in the presence of bother, in the presence of absence of sense of control over it, a man who has duration of ejaculation that takes at least 60 minutes to reach climax was pretty good at distinguishing those guys who had the most problems. However, in clinical practice, in terms of what's practical and useful, and honestly, many people are exhausted well before 11 minutes, let alone 16 minutes during intercourse. An 11-minute time-based criterion was thought to be most useful. And generally what was found to be most bothersome to people when they were really troubled, or what bothers them the most about their issue here, was that if they don't get to ejaculation often and they're having difficulty with it together, that's when people are going to be most distressed. And oftentimes, as you may expect, I think sexual disorders oftentimes have a lot of overlap. So a man who has a problem with erections may also very likely have problems with desire. He may have decreased pleasure. He may have relationship conflicts, and delayed ejaculation is no different from this. Is that when a person has more asexual concern, it is not unlikely that he will also have other sexual concerns going along with it, whether that's cause or effect. Hard to say sometimes, but not at all rare. And so this time-based criterion was a potentially very important contribution, and certainly it's going to open up the door for more research and better understanding in the future. The other important thing we wanted to look at here was that these were a subset of men from this study who reported the most bother, the most trouble with reaching climax, defined as both orgasm and ejaculation. And these men were asked to kind of subjectively rate for themselves, okay, what do you think is causing this? And these were obviously what the patient thought, and that's really important to know. What is the patient's opinion on what's driving these conditions? Because oftentimes that's the most important thing for us to know too, is what does the patient think is going on? And you'll notice that anxiety was one of the most important criteria. Anxiety of some sort was identified in almost two-thirds exactly of participants. And a close second was people feeling they weren't getting enough stimulation, whether that was related to their partner or the kind of sex they were having, or the fact they potentially had a less sensitive penis. It's not rare, especially as men get older, that the sensitivity of the penis may become less due to a number of different conditions. So I think that these two together represent very important causes that are actually quite prevalent in our delayed ejaculation population. And you'll see some other things important too. Obviously partner conflict, medication, specifically SSRIs and similar, having pain. That's not a very common cause of this, but certainly something that some men did implicate. So I think this is a really useful way for us as physicians and mental health people to really think about this and really make sure that we inquire, well, hey, you're having delayed ejaculation. Are you anxious about this? Are you anxious about life? Are you anxious about the world? Are you anxious about your partner? Anxiety is pretty common, and it certainly doesn't help. Same thing. Are you getting the sex you want? Are you doing things you like? Do you like your partner? Is your partner doing things you like? These are important questions to ask. And then fundamentally also asking questions about overall relationships and medical history, all really important and things that we turn to when we really want to understand where a man's coming from. Again, no pun intended. Unlike premature ejaculation, we'll really want to sometimes look more detailed at their medical history. So if they're taking certain medications, if they have medical conditions such as diabetes or some kind of central nervous system problem like a stroke, a spinal cord injury, a neuropathy of some sort, these are all things that potentially are going to contribute and potentially influence a man's experience of orgasm and probably many other aspects of sex too. And therefore, I think we will sometimes obtain this sort of testing that kind of helps us investigate these. And again, this could be biophysiometry, which means sensory testing, and also testosterone levels, again, being potentially quite important. Once again, Dr. Althoff would be the best person to talk about how they execute therapy for delayed ejaculation, but I'll speak on his behalf to some extent, that it comes down to education, strategies, giving self-efficacy and managing interpersonal conflict, finding ways to approach sex as something fun, and managing those anxiety issues that I brought up earlier, potentially all very important and fruitful ways to apply this. And again, I would defer to Dr. Althoff and people like him to really answer best. But I once again recognize the value that comes with mental health consultation and sex therapy, honestly, with a certified sex therapist. Considering, the idea here that many times, or at least in some cases, a medication may be to blame. Obviously, if it's possible, we do strongly recommend dose adjustment, dose titration, meaning limiting, or dose cessation being the best possible solution. However, because some of the drugs that might lead to delayed ejaculation are also antidepressants, this has to be done consciously because there can be really potentially significant consequences of stopping these drugs cold turkey. So it's very important when just considering this to make sure that the doses are adjusted slowly and properly, and certainly not without just cold turkey quitting them. There's some evidence from weak studies that testosterone can be a benefit, but this is only applicable in the context of a man who has biochemically low testosterone levels. And we would not recommend it as a routine recommendation. It is something that could be considered when a man has at least 2 testosterone tests that are low and potentially other symptoms referable to low testosterone. Those would be things that I would want to see in place before we would consider testosterone supplementation. And again, there aren't very many studies saying it makes a huge difference, but it's something that is rational at least. There is at this time no pharmacotherapy. There's no orgasm pill, as much as I wish there was. There is not. We don't have that yet. There is also no evidence that any sort of non-drug related treatment makes a difference either. However, I'm always a fan of trying to tell people to say, hey, think about the sex you're having, think about the sex you're doing, think about what make it feel different or better or more exciting for you, and certainly institute those things within the bounds of what's acceptable to you and your partner. And one example of this from a study done by my friend Christian Nelson at Memorial Sloan Kettering was the notion of, penile vibration. This was not a randomized controlled study. It is something that doesn't necessarily show that there's any particular protocol or way to do it, but it does imply the notion that, hey, vibration feels good. It's intense. It may be more than a partner can provide, or maybe what a man needs at a certain point of his life to achieve climax. And using a vibrator either with sex or as a training thing, certainly not dangerous. Not super well evidence-based either, but certainly not dangerous. And I think I use this mostly as a license to patients saying, hey, think about what you could do different sexually. Think about what might be exciting to you. There is also a pharmacotherapy known as cabergoline. Once again, very strongly, I'll say it again, this is off-label, not a standard of care, not an orgasm pill. It is, however, the only drug that has a very large study behind it. Now, I'll say this is not a randomized controlled trial. This is not a drug designed to enhance orgasm. It is hard to say from these data whether or not the pill itself or was a placebo, because there was no placebo arm to compare these men to. But there was, in this population of men from Baylor University, some improvement in people who were taking this treatment. And again, my personal experience with it has been that there are some people it seems to help, although not all by any stretch. There are some other pharmacotherapies too, most of them, again, centering around the notion of enhancing dopamine activity, that kind of pro-orgasm neurotransmitter that we all have. So these are things that are interesting, and I think they're probably most useful as fertile grounds for future research. Not necessarily, certainly not FDA approved, but certainly things that can be talked about and discussed under consultation with a healthcare provider. So I'll wrap it up. And again, thank you all for your indulgence and letting me go a little bit over here. These disorders of the timing of ejaculation are prevalent. They can be treated and evaluated, but it's very important first off to define what are we talking about, what is the condition in play, what are the potential contributing factors, and what can we change? What can be changed in a man's life or a man's sexual experience that can potentially resolve these issues without needing to turn to pharmacotherapy. Pharmacotherapy exists, it's effective, it's useful, but obviously my preference in many cases is to try to not use medical therapy when there's other things we can turn to, and I always want to start with that when I talk to patients. With that, thank you very much for your attention. I'm happy, Dr. Alba, to have you back and answer any questions that might have come up from the presentation or anything else relating to other topics in ejaculation. So thanks so much for your attention.
Awesome. Thank you for all that great information. So one thing I was thinking about a little bit, I know like you, a lot of my patients, they may be adverse to taking a medication every day, like an SSRI, or sometimes even on-demand medication, because we do use them sometimes on demand. And so with premature ejaculation, I find they can be adverse, they just don't want to do that. And so local desensitizing things can be very helpful. And I don't know about you, but I've found even one thing that I find helpful besides behavioral things, of course, that we recommend is for non-invasive things is condoms.
Mm-hmm.
They put condoms next to the bedside. They can layer them. Sometimes one will decrease sensation, sometimes 2 or 3. And patients will say that can be helpful. So if you're feeling too much, you can roll another one on. If you're feeling too little, you can roll one of them off. The thing I like is you can change it up as you go, but yet it desensitizes locally that area. You don't have to take a systemic pill, and it can be helpful. So I don't know what you find with your patients, but I've found sometimes that can be a helpful thing to use instead of having to take a medication or a systemic treatment.
I certainly agree with you that the condoms are easier to adjust, because the topical anesthetic, you put it on, you let it sit for a certain amount of time. It has some set effect. The longer it stays, the number you get to a certain point. So it's kind of finding that sweet spot where you're getting just the right amount. Certainly takes trial and error. And the condoms, once again, it's like 1 condom, 2 condoms, 3 condoms. There's a limited amount of, it's not like a thermostat. You have 1, 2, 3 more with that kind of thing. So I certainly I think it's a really neat approach to it that is certainly safe. in terms of pharmacotherapy side effect. Now, the one thing to keep in mind, I'm going to put my public health hat on now, is that condoms that are doubled up are more likely to break. So one is using condoms for prophylaxis from either contraceptive purposes or for safer sex practice. Doubling up on condoms is not a good idea because they're less effective for contraception and safer sex when there's 2 condoms instead of 1. Now, for what you're describing, and Dr. Alba, and certainly if it's not a concern about contraception or STI prevention, I think 2 condoms is perfectly fine to use. Just recognize they may be more prone to breaking when they're doubled up like that.
No, super good point. And I always remind people that. And I always tell them too, hey, by the way, you're going to want to tell your partner, hey, I'm adding these condoms so that I feel a little less because I just want to last longer, and have a conversation. So your partner's like, why are you suddenly wearing a condom? Is there something that I should know that I don't know? Right. So it is a discussion you need to have. And absolutely, if you're using it for prophylaxis or you're using it for STI protection, you don't want to do that. But I find a lot of couples who are in a longer term relationship, they're not using it for any of those things, find it really helpful. I say, put them right at the bedside. Because like you, when they use the numbing medications or the numbing spray or whatever that might be, sometimes they need to wear a condom over that so it doesn't transfer. Some of those medications do, some don't. But I also say too, once you're numb, you're numb. There's nothing that I or anybody else can do about it. And so you got to remember finding that sweet spot, like you said, of what's too much, what's too little. I always say start low, go slow with whatever you're trying. But once you're numb, you're numb. Whereas I kind of like with the layered condoms, you can mix it up as you go along.
Totally. Yeah, I agree. Totally.
Also, I was thinking when you were talking about delayed ejaculation, I found so often I have to pull that apart with patients because they're confused about, sometimes they're like, I have delayed ejaculation, I'm not ejaculating. And then when you get to it and you start questioning them, this is where the history is so important. They are climaxing, they are having an orgasm, but the ejaculate is not coming out like it used to for whatever reason. Maybe because they have a prostate disease, benign prostatic hyperplasia, or they're on a medication or a treatment for that. Or I've even had younger men who are like, it's not like it was, it's hardly coming out and everything. And we start pulling it apart and understanding it better. And they're ejaculating, sometimes multiple times a day. And so now the ejaculate volume isn't what it was. It's not propelling like it was. And they're upset about this. And so I think it's so important to work with the patient and the person to understand what the heck is really going on here and how can we really help you? Because sometimes it can be something simple where we kind of, once they understand, you're not ejaculating because you're on this medicine or you had this procedure for your prostate but you're still feeling that orgasm and kind of pulling that apart. They may still be like, yeah, it doesn't feel as good as it used to or whatever that is. And then that's a different issue. But I find there's a lot of pulling the onion back and getting to the bottom of what's really going on.
Well, you're right that we use the term delayed ejaculation almost universally when we talk about this. And in the medical literature, it's the same story. But honestly, like you're saying, Jeff, a lot of it is, unless someone's trying to procreate, if you're actually trying to get somebody pregnant, from the medical perspective, the ejaculate is redundant and unnecessary. It's what happens up here. It's the pleasure, the orgasm that really matters. Now, having said that, from my medical perspective, I think that ejaculation itself is prized and prioritized. And I think all you have to do is look at explicit media to see that so much of what is thought of as essential to sexual experience, and many men have the notion that the act of ejaculating, even if they're not trying to get somebody pregnant, is a big part of sex for many, many men. And if it's not there, they can still have an orgasm. They still feel all the pleasure, but where's my semen? Where'd my semen go? Where is that? I think it's interesting because there are not a lot of data on this, but what data do exist, again, speaking of heterosexual couples primarily, many female partners of men are like, they don't really prioritize. They like their partner orgasming. They like having sex with their partner. They don't particularly relish the ejaculate in and of itself, even though men oftentimes do. So I think it's perhaps a misperception. So there's a lot to unpack there, Jeff, and I really appreciate you bringing it up because as I had that one slide about it, there's orgasm problems, there's absence of ejaculation problems, there's ejaculate being less than it was. And I think, most men, we think back to teenage years, we remember shooting across the room, back when we were having sex with ourselves only, that we didn't have a partner. Yep. And you're 18, so of course everything works like clockwork and you can do it 5 times a day, and that's just the way it is. And again, it's a huge volume every single time across the room. I tell people this somewhat tongue in cheek, but hey, sorry, buddy, but it's all kind of downhill after age 18. Not that your sex life is over at 18 by any stretch at all. But I think we have to acknowledge that, yes, the force and volume of semen that is expelled is going to be less as we get older.
Mm.
If you're having sex multiple times in a day, it's going to be a lot less, especially as you get older. And I think the sensations of orgasm might feel differently too, but they're still good. And I think what we have to kind of prioritize is sex that still feels good, even if it wasn't like what it was 5, 10, 20 years ago. I think that's just the natural part of aging and what we have to kind of reconcile ourselves to.
Yeah, and you bring up a really good point. Different people value ejaculate different. Several of my gay men have told me, in our culture, this is a big deal. Ejaculate matters. It matters to us. It matters to me. It matters to us. And so I think knowing who you are and does it matter to you, and is it really important? Because as a medical community, we're like, if you're not trying to procreate, how much you expel and ejaculate, all that, it doesn't make a difference one way or another, but it may make a difference to you. And so we got to zero in on that, and that can be a little tricky. I think
well,
too.
And Jeff, if I
Yeah,
could, I work in San Francisco, so as you might guess, I have a lot of gay male patients, and I have the same observation. And there's data on this too. If you look at peer-reviewed literature, and if you look at post-prostatectomy patients, so these are men who have their prostates removed for cancer, and after that, ejaculation doesn't happen, at least not semen. Some people have some urine leakage, but they don't have semen anymore. It's not really physiologically possible. And what's interesting about data on that population that's been done, where they look at both gay and straight men, all men are bothered by erections at a pretty equivalent, level of how much bother gay men and straight men have versus with regards to their erection function. But in gay men in particular, the amount of bother they have from the absence of ejaculation is almost doubled compared to what you see in straight men. So you're exactly right that, in certain populations, and again, gay men is one example of this, where semen itself is prioritized. And again, not every gay man, of course, but it's more likely compared to straight men that semen will be prioritized in and of itself as part of the experience. And that's why it's really important, I think, for urologists like myself and people who treat prostate problems to really know that up front and say, hey, look, these medicines like alpha blockers, these surgeries like TERP, these things can have a very substantial effect on ejaculation. And even if you're not trying to get pregnant, if you're going to miss it when it's gone, we really need to think very carefully about how and if we treat these problems, because you might lose something very important to you.
Yeah, and my prostate cancer group that I run at Gilda's Club and with Zero, again, some of the men have really talked about the impact of that non-ejaculate orgasm, or the changes or diminish in orgasm, and how it's affected their life and how it was really important to them. And they wish that the urologist had understood more of how important it was. And they really felt like, as a post-prostatectomy patient, that talking about the lack of ejaculate and the changes in orgasm weren't highlighted as much as maybe the erectile dysfunction or the other possible problems. So I think it's a really big deal, is you out there who are listening, knowing who you are and what's important, and making sure your doctor knows that. And then us as healthcare providers, advanced practice nurses, physician assistants, and urologists, knowing what's really important to you in particular when you go into prostate cancer treatment or even BPH treatment or whatever it is. So I think it's a really important, valuable thing. One other thing I was thinking, what you were saying was about the comparing. So I work a lot with my delayed or diminished climax or ejaculation patients who are upset about difficulty reaching ejaculation, trying not to compare, staying in the moment, staying anchored to the feelings, the sensations, and how important that is. But it's a frustrating problem, delayed ejaculation. I know you probably feel very similar. I wish I had better solutions for those patients who truly have like neuropathic or nerve damage, or the medicine's changing them up. It's just not getting them to a place where they can climax anymore. So frustrating. I don't know what you find, but I feel my hands a bit tied with what I can do to help them too. But I find vibration and things can be helpful. What do you find?
I tell them, think about the position you're having sex with, think about what you're doing, think about fantasy, think about sex toys, think about vibration being a very common one. So it's sort of like, what levers do we have to pull? Unfortunately, neuropathy, neurologic conditions, we don't have a lot of good solutions. I'm not a neurologist, as I said earlier, but from what I know, we don't have a lot of great things to restore nerves or change neuropathies. So in the end, what I try to use this biopsychosocial model that we talk about different ways that sex is experienced and the things that influence our biology, our bodies, and our medical conditions, our internal psychology, what we think, and social, meaning our relationship with our partner or partners and how we feel about sex more broadly. So biopsychosocial, within each of these domains, when we're talking about something as complicated as orgasm, we really have to think that there's probably some from each of those columns that influences our ability to reach climax. And some of these things we can intervene upon, some we can't. But I just, again, try to invoke, okay, fantasize more, talk to your partner. What can your partner do differently? Can you try a different sex position? Biologically, can we change your medicines? Can we use something more intense? Can we give you more intense stimulation because you might need that now because you're less sensitive than you used to be? Let's pull all the levers we can, within the bounds of what's acceptable, what the patient's willing to do and what their partner is willing to do. But let's try everything we got. And like you, Jeff, I tend to like the notions of doing things that are non-medical, certainly non-invasive first, because I think a lot of people can at least reach a point of, hey, sex is pretty good. Sex is good. It's not, again, maybe it wasn't what it was, but it's still good for me and my partner, and I'm able to enjoy it. And if you can do that with things that are not pharmacotherapy, that are not drugs, that's always better, but the drugs are there too. It's not enough.
Yeah, thank God we have we have choices, and I think that's really important. And again, understanding where the patient is and meeting them there and what they want to do. I have a couple questions for you. Question one is, how can ejaculation disorders impact a man's self-esteem, relationship, and overall quality of life? Is what someone was asking.
No, it can have a very substantial impact. And again, it depends, once again, we have to talk about what is a specific disorder. Sorry, I have a helper coming here to join me. She's heard all this talk. Full disclosure, I'm a urologist. My wife is a gynecologist who specializes in women's sexual function. So this poor child has heard more than she perhaps should have, but over here.
Welcome.
It can have I'm talking to my friend Ella, so give me a moment to talk, okay? So it can have a very substantial negative effect. And I think that obviously there's the direct impact it has on the man's experience and his partner's experience and what goes on between them. I would say, Ella, can you sit over here for a moment?
I want to sit here.
You can, I'm talking to people. So one thing that it can do, I think part of what makes it challenging though, and part of what makes it so very difficult is what people respond. So how a man responds to the problems he's facing. If he gives up, if he's defeatist, if he withdraws from his partner, if he says, I'm going to give up and not try, or I'm less of a man, or internalizes some kind of very negative self-script or some negative self-efficacy, to use a term that Dr. Althoff would use about sense of being able to accomplish things and be good at things. Men are very performance focused. Being a man myself, I know that we think about, we want to be awesome, we want to win, we want to do everything great. And so much of male sexuality is about that. So ultimately, no, you can't, Sophia. So what we're talking about here is, again, men developing the skill set where they can really, men developing the skill set to understand that basically they can still be good at things, and they have to develop that confidence in themselves. So the loss of those things can be a really significant impediment. That's probably the worst part of it, when a man loses a sense of self-confidence.
For sure. I think those are some really great, valid points. So the second question, I think you've answered pretty good. And they were just asking, they're embarrassed to seek help and not really sure where to start. Do you have advice on where to begin with the problem? And then also, if you want to put up there, Vic, I put to find a provider, Sexual Medicine Society of North America. Both of us are members of that, Dr. Shindel and myself. And they have a find a provider under resources, as well as the American Association of Sexuality Educators, Counselors, and Therapists. You can go there to find providers as well. Is there anything else you want to add? I know you have given us more than enough time, and I want you to be able to enjoy your lovely family.
Yeah, I appreciate it. So let's sit over here. So I think those two resources are the most important. So there's a website called sexhealthmatters.org, which is actually a patient-facing component of SMSNA. ASEC, and also starnet.org, the Society of Sex Therapists, Advocates, and StarNet, SSTA. I'm losing track of the acronym right now, but StarNet is another really good resource for people who are vetted, experienced sex therapists.
Yep.
Obviously, urologyhealth.org is a website sponsored by the American Urologic Association that is not specific to sexual function stuff. But since we talked a lot about prostate, and prostate is so very essential for orgasmic responses and ejaculation, and the things that are done for the prostate are very influential, and prostate cancer is a huge topic in sexual wellness and function. These are other resources that are quite useful. this has nothing to do with ejaculation per se, but I'll also put out that ISWISH, the International Society for the Study of Women's Sexual Health, we're not here talking about women, we're talking about ejaculation in people with prostates. So that's kind of the topic of the day and something that I think is really what I'm here to talk about. But certainly ejaculation disorders can have a major influence on partners, many of whom are women. And I think understanding women's experience of sex and understanding that ISWISH is an organization dedicated to that purpose can be very valuable too. So I'm always a big fan of promoting what they do as an important adjunct to what we do for our men or people with prostates, to be more inclusive about the terminology, who have ejaculation disorders.
Definitely. And we do have some wonderful talks coming up for women specifically. And also, don't forget, when it comes to the prostate, Dr. Alex Glazer is going to join us to talk about diseases of the prostate in the next month. And Dr. Brian Helfand, a world-renowned urologist who is a prostate cancer genetic researcher and does surgery and treatments for prostate cancer as well, will be joining us within the month. So lots of good stuff coming up. So many topics, so many wonderful speakers, and you were phenomenal. I would like to just really thank you for sharing so much good expertise and evidence-based information with all of our listeners. We're going to I'm going to do a little bit of a centering closing exercise next, and then we'll talk about what's coming up next week. So you know how we like to end the podcast. Let's take a moment to settle into a comfortable position. And if you're able, gently close your eyes. Put your hands wherever they fall naturally, on your lap or on the chair, and just get into a comfortable position. Inhale slowly through your nose for about 4 counts, and then hold it for a moment. And exhale slowly through your mouth for about 4 counts. Continue that breathing pattern. Inhale for 4 to 5 counts. Exhale for 4 to 5 counts. As you do this, let your shoulders soften. Let your jaw relax. Let go of any tension or judgment. Breathe. Breathing is powerful. I can tell you how I got through my vertigo was breathing. I can't tell you how much breathing helped me. And I was doing some definite breathing. So breathe with me. Deep breath in. Slowly, gently release. And as you do, remind yourself, I am not defined by my challenges or sexual problems or medical problems. I am open to learning about and improving my sexual health. I am worthy of understanding and care. I am enough. I know it's been a lot to take in. You've done a great job. When you're ready, gently open your eyes, grounded, present in this moment, this miraculous moment, and ready to take on what matters most. I'm so glad you were able to join us for a lot of really great information this evening on ejaculatory disorders. What's coming up next week, Vix?
Have you ever felt unsure about intimacy and relationships? You're not alone. Understanding gender identity and sexual orientation can seem complex. Gender identity is how individuals perceive themselves. It can differ from biological sex. It also goes beyond heterosexual and homosexual labels. It includes bisexuality, pansexuality, and more. When partners openly communicate about their identities, connections deepen. This creates a safe space for vulnerability and understanding. Join us April 29th to learn more.
Wow, thank you so much for joining us this evening. I really appreciate it, and thank you to our guest who was. Thank you so much, and it was so good to see the little ones as well. Thank you for joining us, everybody.
Thank you
for sharing your dad with us. We appreciate it.
Yes, thanks. I appreciate your patience, Jeff. I'm sorry they busted. They're pretty fun.
Please.
So,
Thank you for joining us, and I'm so glad that you were able to join us. And thank you so much for sharing your expertise. So for this week, we will see you later. Have a good one.